move to our last speaker, and not the least, Dr. Nazir. He is an associate professor in Government Institute of Medical Sciences in the glittering city of Noida. It's a flourishing one, which is coming up in a big way. In the just near the national, it is part of the National Capital Territory, and is a very big hospital. I have visited a place and I'm quite impressed with the work they're doing there. And I'm sure that Nazia will guide us exactly how to take on the patients out of ventilator. And over to you, Nazia.
Thank you so much, sir. So good evening to all. So I'm Dr. Nazia. So I'll be speaking on weaning from mechanical ventilation. I hope you are able to see the screen.
Yes, you expand your slides. You take it, make it full screen. Yeah, fine. Now
so as the previous speakers have already spoken about ventilatory support. So ventilatory support was to unload the patient's respiratory pump, and I'll be speaking about weaning. That is the process of reloading this respiratory pump. And as we all know, the total time that the patient spends on the ventilator, 40% of the time is spent on the weaning process. So weaning is defined as the process of withdrawal from mechanical ventilation and to transfer the work of breathing from the ventilator to the patient. This may take many forms, ranging from abrupt to gradual withdrawal from ventilatory support. In majority of the patients, weaning is a simple process. However, in 10 to 15% of the patients, it may extend over a period of 48 to 72 hours. And another 5 to 10%, it may be a gradual weaning over a long period of time. And in 1%, the patients may become chronically ventilator dependent. So why wean early? It's because a patient on ventilator, it increases his length of stay in the ICU. This will adversely affect his outcome, both in terms of morbidity as well as mortality. There is increased risk of ventilator-associated pneumonias, adding to the healthcare costs and decreasing the ICU bed availability and hospital beds. Now, according to the weaning process, the patients can be categorized into 3 groups or categories. That is the simple weaning, difficult weaning, and prolonged weaning. In the simple weaning, the patients proceed from initiation of weaning to successful extubation at the first attempt without any difficulty. While as the difficult weaning patients are those who fail the initial weaning attempts and require up to 3 spontaneous breathing trials or as long as 7 days. While as the prolonged weaning patients are those who fail at least 3 weaning attempts or require more than 7 days of weaning after first spontaneous breathing trial. Now, from admission to discharge, there are various stages of weaning in a mechanically ventilated patient. So starting from the treatment of the underlying cause for which the patient was first put on mechanical ventilation, then you have to assess for the readiness of weaning, then give spontaneous breathing trials, and if they are successful, proceed to extubation, and if extubation fails, then reintubation. So we'll be talking about how to evaluate the patients who are to be weaned from mechanical ventilation. So a daily routine needs to be followed up in every patient, and the things to be seen are whether the underlying disease has been resolved or not, or there is improvement in the underlying disease. Give sedation vacations, check the core body temperature, check the hemodynamics. The patient should have stable hemodynamics with the absence of any active myocardial ischemia. Normal hemoglobin levels. GCS should be above or equal to 13 with no major metabolic or electrolyte disturbances. Now, the weaning criteria are divided into 2 types, that is the clinical and the objective criteria. In the clinical criteria, the patient should have adequate cough with absence of excessive tracheobronchial secretions. The underlying acute phase of the disease for which the patient was put on ventilation, the first phase, should be resolved, and the patient should be hemodynamically stable. Among the objective criteria are the ventilatory, oxygenation, pulmonary reserve, and other pulmonary measurements. We'll be dealing them one by one. So the ventilatory criteria is that a patient should have a PaCO2 of less than 50 with normal pH, should be able to generate a tidal volume of more than 5 mils per kg, with a respiratory rate of less than 25 to 30 per minute, and a minute ventilation of less than 10 liter per minute. In the oxygenation criteria, should have a partial pressure of oxygen of more than 60 millimeters of mercury at FiO2 of 0.4, with maintaining a saturation of more than 90% with 0.4 FiO2, and a PF ratio of at least 200 and shunt fraction of less than 20. In addition, the patient should also be able to have a vital capacity of, should be generating a vital capacity of more than 10 mils per kg and maximum inspiratory pressure of at least minus 30 centimeter of water. However, both these parameters are patient effort dependent and require patient cooperation. For these, we can, if the patient is not cooperative, we can go for other parameters like static compliance, airway resistance, and dead space ventilation. These are not dependent on patient cooperation. So patient should have static compliance of at least more than 30 mils per centimeter water. Observe the trend of the airway resistance, and dead space ventilation should be less than 60%. Now, an important index for weaning, which was described by Yang and Tobin in 1991, is the rapid shallow breathing index, which is calculated by dividing the breathing rate of respiratory rate by the tidal volume in liters. And a rapid shallow breathing index of less than 105, it predicts a successful weaning attempt and has a sensitivity of 0.97. Another weaning index is the CROP index, which is short for compliance, resistance, oxygenation, and pressure index. It evaluates the pulmonary gas exchange and balance between demand and reserve. A CROP index of more than 13 mils per breath per minute favors weaning. However, this index is less sensitive than RSPI. Now, the ultrasound has made its is useful in ICUs, and it can be used for assessing the readiness for weaning, as this modality is non-invasive, bedside, with no radiation hazards, and can assess the diaphragm. So in this view, the subcostal view is taken and the diaphragmatic excursion will be observed. A diaphragmatic excursion of less than 1.1 centimeter on either side, whether we take on the left or the right hemidiaphragm, is usually associated with poor indicator for weaning. So a mean cutoff value of less than 1.1 has a sensitivity and specificity to predict a successful extubation to be 84 and 82% respectively. Now, another diaphragmatic index which is useful for predicting weaning is the diaphragmatic thickening. So for this, we use the thickening fraction of diaphragm during spontaneous breathing. So in this case, the thickness is taken between that is taken as the difference between the end inspiratory and the end expiratory thickness of the diaphragm. And Ferrari et al. Have reported that the thickening fraction of more than 36% measured during spontaneous breathing trial is associated with a positive predictive value of 92% and a negative predictive value of 75% for success of weaning. Another index which can be taken into consideration is the lung aeration loss, which can be quantified by a lung ultrasound. It gives a dynamic assessment of the lung aeration and can be validated by a score that is a lung ultrasound score. So when we get a normal aeration pattern is like this, in which we'll have majority of the horizontal A lines with only 2 or less vertical B lines. So we'll give a score of 0 is given. Then for moderate loss of aeration, multiple regularly spaced B lines can be present, that is the vertical lines can be seen, but they are only limited in the limited area of the intercostal space. So a score of 1 is given. For severe loss of aeration, multiple coalescent B lines in the intercostal spaces will be observed, and a score of 2 is given. And for complete loss of aeration, you'll be able to see lung consolidation with or without bronchograms. So 12 areas will be seen, 2 in anterior, 2 lateral, 2 posterior, and a maximum score of 36 can be given. So this lung ultrasound score can be give a likelihood of success of extubation. So value of less than 13 is associated with high likelihood of extubation. A score of 13 to 17 with the intermediate score, and score of more than 17 is associated with high rate of failure of extubation. Then is the brain BNP, that is the brain natriuretic peptide, or the B-type natriuretic peptide, which is secreted by the ventricular cardiomyocytes when there is stretching of the ventricles. So this is an independent predictive factor for failure to wean after cardiac surgeries. So this parameter, it suggests that the ventricular function needs to be optimized prior to liberation from mechanical ventilation, and BNP level in the blood of more than 299 nanograms per liter at the end of the SVT, it identifies with weaning failure. This BNP has a sensitivity of 92 and a specificity of 87% in terms of weaning success. So for during weaning, before giving a spontaneous breathing trial, in high-risk patients, you can go for echocardiography and do the lung ultrasound to see the aeration score. Then during the weaning, for predicting the weaning success, again go for lung ultrasound and diaphragmatic excursion, and or the diaphragmatic to see for any diaphragmatic thickening or dysfunction. Then if there is a failed SVT, diagnose the cause with the help of echocardiography, and again go for lung ultrasound to see lung score. Now the methods of weaning, there can be traditional method in which slowly the ventilatory support is reduced from the control mode, or the modern approach in which the various clinical criteria and various indices are taken into consideration, and then this is followed by giving a spontaneous breathing trial. So rapid ventilator discontinuation, these can be tried in patients with no underlying comorbidity, such as those post-operative patients, and usually these patients are on ventilator for less than 48 hours with a good respiratory rate and maximum inspiratory pressure. Give a spontaneous breathing trial for 30 to 30 minutes and extubate if there is no limiting factor. So spontaneous breathing trial can be given in the form of a T2 trial or the pressure support ventilation or Cpap. The advantages of giving T-tube are that it tests the patient's spontaneous breathing activity and helps in a faster weaning. However, this disadvantage is that there is no alarm system, and it requires very careful monitoring. So this is the classical T-tube adapter. For weaning with the spontaneous breathing trial, that is this T-tube trial. So again, prepare for the T-tube, do a screening trial for 3 minutes, measure the tidal volume and adequacy of the respiratory rate, give the spontaneous breathing trial. If there is no sign of intolerance like increase in respiratory rate or diaphoresis or decrease in GCS, so extubate the patient. SBT with the use of Cpap, it lets the patient breathe spontaneously. Let the patient breathe spontaneously for 30 minutes. We can use a low level of Cpap to augment the spontaneous breathing, and if the patient tolerates, consider for extubation. So again, where spontaneous breathing trial with pressure support can be used, and this pressure support is mainly used to overcome the resistance of the tube and the circuit. So what are the clinical criteria which will be related to a failure of the spontaneous breathing trial? So observe for PaO2. If the PaO2 is less than 60 millimeter of mercury on an FiO2 of 0.5, saturation of less than 90% on FiO2 of 0.5, rise in PCO2 of more than 8 millimeter from the baseline or more than 50, the rapid shallow breathing index of more than 100 breaths per minute or increase in 20% from the baseline, increase in heart rate of more than 150 or more than 20% from the baseline, or change in blood pressure and presence of cardiac arrhythmias. Then previously SIMV was used for weaning. However, this is not usually used now. So in this case, the advantages it had were gradual transition, easy to use, and a minimum ventilation was guaranteed, and alarm system was present. However, it worsens the fatigue as well as prolongs the weaning period. Then the protocol for weaning with the pressure support ventilation. You adjust the pressure support to deliver a tidal volume of 10 to 12 mils per kg. Then slowly decrease the pressure support by 2 to 4 centimeter of water twice a day to maintain the tidal volume. And if the patient tolerates the pressure support, further reduce it and consider for extubation. Now, as previously has been mentioned that no form of ventilation is superior to others. So similar in weaning, many studies have compared different methods of weaning. So common conclusion is that no clear superiority exists between different weaning methods, whether T2 weaning or pressure support weaning. But SIMV is now considered as the least efficient technique of weaning. The newer methods of weaning which can be used are the use of non-invasive ventilation, BiPAP, automatic tube compensation, then servo-controlled ventilations, then are the newer modes like the smart care, IntelliVent, adaptive support ventilation, and APRV and others. Now in the non-invasive ventilation is basically used to support ventilation without the use of an artificial airway, and is usually used as a bridge for total withdrawal and can be seen as a weaning in progress. So indications are it can be used as an alternative techniques in patients who have failed conventional weaning, especially in COPD patients. Then for post extubation after you have extubated the patient and still he has some respiratory insufficiency, so an IV can be used as a bridge. Then it can help also in expediting the breathing process, but it is there should be some clearly defined indications. It is not recommended for all the patients, and there are some clear criteria for discontinuation of NIV. Now the protocolized weaning is in which developed by multidisciplinary teams, in which they are implemented by the respiratory therapists and nurses to make the clinical decisions. It has been seen that the protocolized weaning results in shorter weaning times with shorter length mechanical ventilation than the physician-directed weaning. Now, newer ventilations have some automated weaning programs. These automated weaning programs, they ensure that the protocols are completely followed and there is better control over the weaning process. Only the patient information needs to be entered, and the predefined computer-generated algorithms will suggest the changes, which is a form of closed-loop ventilation system. And the target will be the lowest possible ventilatory support, which is needed to ventilate the patient. One such example of closed-loop system is the adaptive support ventilation. It is an intelligent mode of both active as well as passive breathing for adults and pediatric patients. It automatically adjusts the ventilation to the lung mechanics as well as applies the lung protection strategies. So this helps in shortening the ventilation time and has been seen in the Hamilton IntelliVent ventilators. Now, another mode is the automatic tube compensation. This is a ventilatory method which aims at compensating for the non-linear drop in pressure across the endotracheal tube. It overcomes the work of breathing due to artificial airways and provides a dynamic ventilatory support of each spontaneous breath by delivering the amount of pressure which is necessary to overcome the resistive load of tube or tracheostomy tube. So the pressure which it delivers is a variable pressure. So similar to this automated weaning is presence of is the use of smart care weaning method, which is seen in the Drager ventilators. It is again an automated weaning system. It measures the selected respiratory variables and then adapts the ventilator output to the patient need by a predefined algorithm, and also automatically conducts the spontaneous breathing trials. However, none of these, an RCT which was conducted, that did not show an advantage of these smart care weaning over the protocolized weaning. So each and every weaning method has to be, the physician has to be aware of these modes of weaning modes, and only then go for these newer weaning methods. Now, what is weaning failure? The weaning failure is defined as either the failure of the spontaneous breathing trial or the need for reintubation within 48 hours following extubation. The various indicators for weaning failure include: there is inadequate gaseous exchange, that so the saturation, patient is not able to maintain the saturation. The PO2 levels are decreasing with the decrease in pH and increase in CO2 levels. The ventilatory or the respiratory patterns are unstable with the respiratory rate more than 30 breaths per minute and rapid change in the respiratory rate. The patient is becoming hemodynamically unstable with increase in heart rate and decrease or increase in blood pressure, and vasopressors are required. Now, coming to the specialized weaning units. Now, the specialized weaning units, these are the acute respiratory care units which are dedicated for the purpose of weaning patients who are on prolonged mechanical ventilation. There are two types of such units. They are the step-down, that is the non-invasive respiratory units which are present in the acute care hospitals, or the regional weaning centers. Now, these type of units, they actually depend on the healthcare structure or of a particular country or a region, but they provide an advantage that the specialized team of personnel will ensure a better level of care, and they actually provide a bridge to home environment for such patients who are dependent on ventilator, and provide more focus on patient care as compared to the conventional ICUs, as well as being cost effective. So the take-home message for weaning would be that weaning plan should begin as soon as the patient has been started on ventilation. Go for no shortcuts. Use spontaneous breathing trial for assessment of weaning. Discontinue the ventilatory support if the patient tolerates the spontaneous breathing trial for 30 minutes. Use of liberation and weaning protocols to facilitate the process and decrease the ventilator length of stay. Thank you.
Thank you. It's a very nice presentation, Dr. Nazia. Weaning is, in fact, what we want to achieve ultimately in mechanical ventilation is weaning, and it is basically liberation or independence from that ventilation which we all want to avoid. And you have beautifully well presented it. One question for you, I see in the Professor Dr. Ali Saad's question, asking about what is more dependent for weaning of ventilation. It is the RSBI or the crop index? You want to answer this?
So could you repeat the question?
Which is more dependable, RSBI or the crop index?
The RSBI. RSBI is more dependable. It has a higher sensitivity.
Basically, we just not depend on only one index to wean
Exactly.
a patient. We see the patient as a whole, and then only we decide. What was the reason that she has beautifully mentioned about the ultrasound and the role of beta-2 inactivated peptide. This is very important because on an echocardiography, we have to understand that the weaning is not only a condition where the lungs are failing, it is the heart-lung crosstalk and the organ crosstalks that are taking place. Every organ has to be checked. Yes, they may not be in a perfect shape, but yes, if the patient can maintain with certain degree of compliance with all these organs, we can slowly take out the patient of ventilator. We have to give a very good Cpap or a BiPAP support after we take the patient out of ventilator. Mandatory nowadays. Most of the patients, we just take the tube out and put on oxygen. Give the patient a bit of BiPAP. And yes, these patients, and slowly again wean the patient out of the BiPAP. So Dr. Saad and Dr. Hessam, Dr. Manna, if you have any comments, please,
yes,
on today's discussion.
Thank you so much for this session. I'd like to appreciate the effort of the MEGA and that had been led by Dr. Saad for bringing such subjects. And this symposium is very beneficial for all of us and also for the juniors. And regarding to the juniors, I'd like to ask Dr. Bikram about very simple how to differentiate and what are the definitions very simply, the difference between BiPAP, PEEP, and Cpap, and who are the patients can get benefits from these three types of ventilation or modes of ventilation, the paralyzed one or the conscious one. So for us first and for our juniors, please can you give a message very simply how to differentiate and how to apply for these three types of ventilation?
Thank you so much, sir. So if we, for that, if the patient in the type 1 respiratory failure, like patient is hypoxemic, PO2 is low, in that condition, we have to give the positive in expiratory pressure, that is the PEEP. And through the other modes of the ventilator, like if we are putting the patient on the volume control or pressure control, then you have to apply this PEEP discussed by Dr. Sarmali madam when we want to recruit the lung. Another one is the Cpap mode. Cpap mode, if the patient is taking the spontaneous breath and patient has the sign of hypoxemic failure, clinical sign and as well as on the ABG parameters, then in that condition we can give the Cpap either the invasive mode or through the non-invasive mode in that condition. So this continuous positive air pressure both in the inspiration and expiration as well. Now coming to the BiPAP. BiPAP, we are giving the bilevel positive airway pressure support, and in that condition we will give if through the NIV mode, then we have to apply the IPAP, that is the inspiratory positive airway pressure, and then EPAP, that is expiratory positive airway pressure. The expiratory positive airway pressure EPAP is equivalent to PEEP. So if the patient has the sign of hypoxemia, then you have to you have to apply the EPAP. So for applying the end expiratory pressure, you have to see how much amount of auto-PEEP developed in the COPD patient. So we will increase the EPAP level at that what level, in that level patient able to trigger the ventilator. And after that, we have to add the 4 on the EPAP, and in that pressure, we have to put that IPAP level, that is the inspiratory positive airway pressure. And then we have to see how much tidal volume patient will make on this difference of IPAP and EPAP. And accordingly, we will adjust the IPAP pressure till the target tidal volume we want to achieve. But at the same time, we have to see whether the patient is tolerating that amount of IPAP pressure or not. So this is the EPAP and IPAP, and mainly it is used for the patient in the case of the acute exudation of COPD patient, or when we are planning to extubate the patient and want to put that patient on the NIV support. So this is the for the BiPAP. Another word is that this BiPAP is that is biphasic positive airway pressure, and that is one of the type of it is one of the type of inverse ratio ventilation, or this airway pressure relief ventilation that comes with the this Drager modes of the Drager ventilator. And in this, it is not similar to this NIV BiPAP. It is the mainly actually invasive mode of the ventilation, and in which it is similar to APRE mode. There are 2 types of the pressure, that is high pressure and low pressure, and then the 2 type of time as well. And here the patient is able to take the spontaneous breathing during the high pressure and as well as the low pressure. So there is chances of the spontaneous breathing also. Only difference between the APRV and this BiPAP is that we are putting the this I ratio is 1:2 in the BiPAP mode, and in the APRV mode we are mainly keeping the inspiratory time is high. So we will not confuse this bilevel and biphasic this positive airway pressure. One is the this is through the NIV, where we are putting the setting the IPAP level and EPAP level, and another is just like APRV mode, where patient can able to take the spontaneous breathing both in the high pressure and the low pressure. So I think
yes, that's clear now. And for Dr. Sharmili, how are you? Just to ask about your experience for the patients, especially who are exposed to COVID and they need support by ECMO. The results, what about the results you see about the ECMO, the survivor from these patients who are exposed and who went for acute respiratory failure, and you need to support this patient with ECMO, especially you know that any big hospital, they have no more than 2 at maximum 2 machines of ECMO. So if we want to support the patient for ECMO, we need a lot of facilities and it is very expensive. What about your experience, Dr. Sharma? Thank you.
Yeah, thanks for raising that question. Actually, very important, because it came in that those desperate days. It seemed like doing ECMO will save the patient. Everybody thought so, but over the time we have come to know that even on ECMO, mortality rate was high, the tune of around 80%, and more so we found it in the both in the first and the second wave. We kind of seen that results are not good. However, the dictate remains, if you can put the patients as early as possible in ECMO, there is a good chance, but it does not guarantee. And overall, from all the big centers which have used high volumes of ECMO, whatever machines they had, the results, mortality rate is as high as 80%. And those were also similar to the just mechanical ventilation, as we ventilated these ARDS patient with their conventional ventilator, with all this, proning and all those things. So ECMO did not do wonders in COVID ARDS cases as we thought so in H1N1 influenza H1N1 pandemic in the year 2009. ECMO was no good or neither better, of course, in this COVID pandemic. So those who did not have it, so need not regret it that they could not do ECMO. And similarly, we have also gone through that stage.
Also, theoretically, I read about perfluorocarbon Do you try clinically for
Say that
liquid
again, sorry?
ventilation, perfluorocarbon, liquid ventilation, liquid
No,
ventilation?
we never tried. We never
Is
tried.
there,
And
is,
neither-
is there this in human trial or in animal trial?
I'm not aware of any, substantial human trial where they have tried this. Probably it was a concept when I was postgraduate in 2002 and 4. I read about it as a theory question, as a theory in textbook. But during my journey in critical care, I've never heard actually, anybody has tried that ever. Even this gases, which are you talk about this, inhaled nitric oxide, etc. They were also tried, and they have been kind of abandoned. They are not, advocated to be used in ARDS cases. So let alone this, liquids not being tried.
I think they tried in animal, not in human. I think
Yes,
like,
yes, probably few animals, but it's never came to human stage at all. Yeah.
okay. Thank you so much.
I think it was, the ventilation is always almost a full day workshop. So completing it is within 2 hours. It's actually a race against time. And I think we kind of managed. I wish people are still awake, I know there's a festive period is going on with their rituals and all. But still, I think we're able to contribute somewhere or other. And thanks, Dr. Asad, once again for your phenomenal efforts and
Right.
trying to keep everything on time and trying to coordinate, synchronize so well.
Yeah. Thank you.
And thanks the
so,
audience.
Yeah, you may just close, Dr. Anchitya.
Yes, so it was a nice and wonderful session. Thank you, Dr. Saad. Thank you, Dr. Esam Manna, to ask those beautiful questions. Actually, very important to differentiate between CPAP, BiPAP, and PEEP, especially for the residents. And I should just want to add one point to this. And better to give any non-invasive ventilation if you're giving through ventilator. Remember that when you're considering the PEEP and the pressure support mode, the IPAP is basically pressure support plus PEEP. Many a times we forget that, and we calculate the pressure support as the IPAP. And obviously, everything has been explained very well by Vikram. Dr. Manna, actually, the end overs and the end, I always quote cricket here. And the last sixer has made, he hit the last six by Dr. Manna. And we are really nice to interact with you. And Saad, you are incredible, actually, And thank you so much, Dr. Nazia. Thank you for such a nice presentation. Thank you, Vikram. Thank you, Sharmili. And thanks, everyone, also the audience, and especially in the holy month of Ramadan, you are sitting with us, most of you, and that's really honorable.